Hello, welcome back to the channel. I'm really excited to continue the conversations that we've been having about the health resolution that's coming up for the beginning of the season for LDers. I think that has been a really interesting resolution to talk about because there are some really interesting differences between the way in which the resolution is being proposed for LDers at the high school level and the way that this resolution was previously debated at the college level a couple of years ago. And I think that there are definitely lots of ways in which they kind of like cross-reference each other because the main kind of questions that revolves around single player. But I think especially when we're talking about critical ground and when you're talking about critical affirmatives, I think that there are a lot of places where the kind of like texture differences in the wording of the resolution changes maybe some of the places in which critical teams can kind of find room in order to really play with the way in which the topic is really asking the question of like how care is delivered under a single payer system. And so in this video, I kind of want to talk a little bit about the differences not only between those two resolutions, but what the room is for critical affirmatives in the health resolution. I really want this lecture to be a place where I'm able to really talk about some of the main places where I think critical affirmatives were really being able to kind of like find their ground in order to distinguish it from the kind of K-neck video that I did before, and really talk about what I think are some of the really cool possibilities in terms of some of the questions that could be asked from these critical affirmatives and the history that they should really be pulling from. I think there are a lot of ways in which the critical affirmatives under this resolution could be extremely diverse and have various types of ways of approaching different responses to different types of problems that come up when you think about the problem of care and when you're trying to think about what care is really defined by and what it means to actually care for a population. And so when I think that we're trying to figure out what the process of this resolution looks like for critical affirmatives to really dive in and figure out like what their kind of approach is, there are a lot of ways to kind of like think about like how the questions of life, humanism, etc. are central, but also like what are the kind of like questions of like how care is operationalized and what does it mean for care to be contained in a hospital, and what does that historically meant for various types of populations that have not had access to being cared for, whether by the nation state, whether in hospitals, et cetera, et cetera. So let's just kind of like start off at the top here. So when we're first kind of just thinking about what are the kind of like central criticisms of the resolution, I think that going beyond just kind of like naming literature bases and just throwing them out there and talking through them, I think that when I'm trying to think of the resolution itself, it's really asking first the question of within the context of the United States, what does a single payer system look like in terms of being able to deliver and ensure care for people across the United States? And I think that a single payer system has a really interesting historical kind of legacy because a single payer system is something that is like obviously like from the topic lecture, if you watch that video, something that originally starts in Europe, but because of the ways in which World War II and the Cold War actually end up developing, the kind of call for single payer gets branded as a very socialist call by the activists and people that are really calling for a more socialized kind of like medical approach to the US's health system earlier on when we're talking about like the 1960s, 50s, etc. And I think that it's really important to kind of like denote that as a kind of like shift and change in terms of the way we're thinking about single payer as like a kind of political idea that has started as a kind of way to weaponize like ideals about like what it meant to like access government resources to everyone as ideas for like socialism, communism, etc., to fear people out of like getting rid of out of voting for those ideals or voting for people that had those ideas or held those political platforms, or to work against and pathologize activists that were using kind of like those kinds of like socialized medical concepts in their own types of community care in order to create and justify various forms of policing, various removing various types of programs, etc. And so to see it kind of like resurge as something that becomes like the telos for a need of the U.S. to just no longer remain this kind of democratic first world outlier really rings like a really interesting bell when you're trying to think about like what is kind of like the nature of why we're even asking for single payer in the first place, and what does it really mean in terms of like how it kind of like is laid through the historical relationship of how people have been creating care on the ground in the first place. Not only do I think that this is like obviously a reason why it may be questionable the kind of like motives for the US to institute such a system, but I also think there are a lot of questions to be asked in terms of what is the relationship between activism and governmentality, and what is the way in which governmentality is forced to respond to activism or community care when it is done in such a way that it kind of like changes the way in which people think about like how we should have access to particular types of living conditions, etc. And what does that kind of mean for like how we think about ourselves as people? I think that when you're thinking about like how the resolution when it's like written by itself kind of gives room for these types of criticisms, I think that it's extremely important to think about like the actual kind of like wording of the resolution. The difference between there are two main differences between the way that this resolution is written in the LD context versus how it was written in the college resolution a couple of years ago. The first difference is that it doesn't say the United States federal government, which is huge because it just means that the United States is a geographic location or a geographic region that is about states and territories, right? And being able to access care in those states and territories, which means that the system of like care, the system of coverage does not have to come from the government itself, because single payer does not mean government. Single payer just means finance from a single like agency, community, whatever, from a single payer, right? And so I think that when you're then thinking about what that means in terms of the other difference between this resolution and the other resolution, is that the other resolution was a specific question about was a specific resolution about the question of insurance, which is about the way in which you finance care, i.e., what are the ways in which we could think about the funding needs for what makes care deliverable. But on this topic, the resolution is written to ask the question about care, which means it's specifically about the quality of being able to access care for those people. Because even if you look at the World Health Organization definition of what universal health coverage looks like, it's not just about coverage being accessible. It is about the ease of its access. It's about it being, universally accessible to various communities in the same manner. And so what does that mean in terms of changes the terms of like how we have to think about health in the first place? And how can achieving those means be impossible based off of the way in which the US is kind of already structured to provide certain communities with comfort, and the way that it's in order to make certain communities healthy in order to stop others. I think that this means that you have so many ways to kind of like continue some of the major themes that I was talking about in the video before. If you've seen the critical neg video, where we're really asking questions about like the kind of like idea of what life is preserved in the name of other life. How does preserving life mean that other life die out? What does that kind of like relationship mean in terms of like why a government-based health program is like inevitably doomed to create forms of like sacrificial groups, etc.? And how does that like ensure particular types of violence? And I think that there are so many ways to think about how the increase of like just access to health services historically have not actually meant a socialized, like communally cared for system. Even if you think about the kind of like 1960s health activism that I think will be so important in this resolution, where you're talking about the Black Panther Party and the way in which they were thinking about, changing community health clinics in Oakland, and the way that that changed and moved to places like Chicago, New York, Detroit, etc. The Young Lords who in New York took over public hospitals and took over the kind of like public trucks and that were being used to test people for various types of diseases, because that access did not actually mean that people were able to use them during their work hours when they were trying to make sure that they were being able to bring money home for their families. So what does taking and stealing those trucks actually mean for being able to make them more accessible to the population? When you're thinking about ACT UP, the development of things like, for instance, the AIDS crisis and the way that it has changed to how we think about the development of pandemic response, right? And COVID-19, the way in which we think about having to map and particularly think about which populations are the drivers of particular diseases in order for us to treat them. How does that also contribute to pathologization, the idea of the ideas that we hold about those populations, the way it carries through into mechanisms of policing and other forms of violence? And even if you go outside of the US into things like the Zapatistas and other international examples, there are so many ways in which I think you can kind of like pull various types of histories of health activism to kind of like think about different types of ways that care can be explained through the kind of like a theory that you want to use in order to think about redefining how the kind of like government is trying to institute care as something that is pushed through only public hospitals and public resources, etc., and why that kind of idea of the public in the first place is something that is inevitably closed out to particular populations. And I think that the final thing that I really want to kind of like talk about in this lecture is the idea of just like the futurism portion of the resolution, which I think was really slept on when I was debating the resolution, which I think can be really good here. When you're talking about a single payer health resolution, you're talking about the idea of people being able to access care. And so, like I said in the other video, the idea is that the health of the human becomes part of the individual. The kind of like ability for us to like think about perfecting the human genome or perfecting the human body so that we can get rid of all diseases becomes a part of how we think about what innovation and driving medicine is actually trying to get to the future of. And how does that create and suture a kind of future of eugenics, where we're able to think about how we choose and think about what type of populations we want to have in the world? How does that move us closer to whitening our population, to trying to think about how we, for instance, sterilize those that are disabled or not seen as fully functional as humans, right? What does that mean in terms of our futuristic processes for how we think about the concept of the house? And why is that a major redefinition of that necessary before we kind of are able to establish any other system of care? And also, how are we able to use this kind of like apocalyptic future where we're kind of like changing the way in which the human body functions? What does it mean to question like the relationship between life and death? I think that there are so many really interesting ways that questions of things like zombies and other kind of like afterlife kind of like questionings of kind of like letting the body become a toxin or something that changes the way in which we're able to relate to space socially can be really interesting ways of disturbing like how we're able to think about care, because the question of how we're able to think about like the question of life is about being able to perfect, like I said before, this human body. And so how does things like these things like the zombie and these other kind of monstrous forms really represent a decomposition of the violence that is created through the kind of like organization of things like the human, of health, etc., and thus create a different way for us to think about the context of care. Hopefully this video has been really helpful for helping you draw some ideas of what you can do on this resolution, giving you some more kind of broader scope about where is the kind of room for critical affirmatives to move on the resolution. And hopefully you'll tune into more videos that will be showing up on the channel. Thank you so much for tuning in as always.